So good evening all and welcome to today's webinar. Uh, so this webinar is being organized by Indian Psychiatric Society, Psychopharmacology Specialty Subsection. And thank you all for taking out time and joining here. The theme of today's webinar was selected because pharmacotherapy for the longest time has revolved around just a few receptor systems and mostly monoamines. And while they have served us well, but it's time to look further, especially that is also the clinical need. We all have patients which don't respond meaningfully. We are always looking for newer ways in which full remission can be achieved and probably side effects are less because that will improve the adherence. So this treatment gap is exactly what has been driving the wave of interest. And considering that, today's session was envisaged as a walking tour of time of that newer landscape uh, where some of the newer receptor targets and the mechanisms might become the pathways for drugs. And some of them are already reshaping how we look at disorders, and few of them are already in clinical use probably. But let's listen to and participate in today's session. And now with this background, I invite, we have with us the chairperson of the session, Dr. O.P. Singh, sir. Now, sir needs no introduction. Very briefly, sir has been the past editor of Indian Journal of Psychiatry in 2018 and 2024. So that's very long term as editor of IJP. He is the president-elect Indian Psychiatric Society and has authored more than 120 scientific publications since then. He's also recognized among the world's top 2% scientists in the Stanford global ranks. And he's also has been distinguished clinician, teacher, and academic leader in the Indian Psychiatry. So we welcome you, sir, and thank you for chairing this session. And may I invite you to give your opening remarks for the session and also introduce today's speaker.
Let Dr. Marwale speak. I will give opening remarks when the formal scientific session starts. So take comment from Dr. Marwale, if we can give.
Yes.
And then we can move because the president is not there. So then I will give and invite, and then we'll go to scientific session.
So
Dr. Arun Marwale, sir, your audio is not clear. Maybe you can switch off the video for some time. The audio may be clear.
yeah.
Marwale sir, not audible most probably. Oh, sir.
Feedback of the other meeting is coming.
Mhm. Okay, let us. So, uh, warm welcome to all of you, and thank Dr. Ramandeep for kind introduction. And of course, this committee is very important because most of us earn our livelihood by psychopharmacology. So it is very important to do things in and learn theoretically also. Most of the psychiatric drugs has been developed first, and then back calculation has lead to kind of functioning and receptors knowledge. So uh, this is. Can you make slideshow of this second slide of introduction, Partho? Yes. Huh. So we need to learn and understand because the newer drugs are coming, which are working also beyond receptors. And we have a very kind of accomplished person in Dr. Govind Kulkarni, who is DPM DNB from BJ Medical College. And he has done lots of phase 3 and phase 4 drug trials. So he's very much interested and aware of all the things what is happening in the field of psychopharmacology. Co-chairperson Psychopharmacology Specialty Section of Indian Psychiatric Society. Co-chairperson Psychopharmacology Specialty Section of IAPP. Senior advisor and EC member Mental Health Committee IMA Maharashtra State. Past secretary Deccan Psychiatric Association. Former national chess player. So again, that will help him to clear things in game of chess in neurotransmitters and downward. And I thank the committee for organizing this wonderful webinar, everyone of the committee. So please, Dr. Kulkarni, please.
Thank you, sir. I'll share my screen. Okay. So I'll start with new age receptors, which are the new receptor targets. Sorry. So what I have done to know what is new is I decided to divide the psychiatry era in three zones. One is psychiatry 1.0, which was supposed to be a crude era, which was 1950s to 1980s. There were discoveries, but the tools were quite blunt. So something like chlorpromazine, haloperidol, they were there. They were quite effective. They reduced psychosis, but caused EPS, caused a lot of side effects. Tricyclics, MAO inhibitors were there. They lifted mood, but these drugs were toxic and lethal in overdose. So then came the era of refinement, which I call as psychiatry 2.0. This was 1990s to 2010. The safety and tolerability of the drugs improved. So SSRIs and SNRIs were introduced in this era. These were safer and less toxic drugs. Atypical antipsychotics were also in this era. They had lesser EPS, but there were some endocrine problems like obesity, diabetes. And the systems in psychosis or depression were still based on dopamine and serotonin. So there were some unmet needs even after Psychiatry 2.0, which were slowness. The antidepressants took around or take around 6 weeks. The negative symptoms, apathy, evolution remained untreated. The cognitive problems of memory, attention remained ignored because we were dealing with or we were preoccupied with problems which were bigger than those. The side effects like EPS, prolactin, obesity just continued, and treatment resistant depression in about one third of cases, the treatment resistance continued. So then came the era of modulation, which we can call as psychiatry 3.0. Now,
it's important to understand that the
modulation era, the discoveries were circuit based, receptor specific precision was there. There were allosteric modulators and receptor subtypes which were being targeted. So psychiatry 3.0 is about new receptors which were discovered. It's about reappraising the existing knowledge on a particular receptor. It's also about from the on and off switches to the dimmers. So psychiatry 3.0 is about beyond dopamine and serotonin. It talks about NMDA receptors, TAR1 receptors, 5-HT2A subtypes, muscarinic receptors, GABA receptors, orexin, neurosteroids, sigma receptors, cannabinoids, and opioid receptors. The goal has been revised to speed, precision, cognition, and restoration. So with this, I think we are all clinicians and we understand or translate all the knowledge in terms of some cases. So I have got some sample cases which are hypothetical, which would tell us about how psychiatry 3.0 goes. Mrs. N, a 29 years old female teacher, had severe depression and significant functional impairment. She was tried with SSRIs for 12 weeks, which is a reasonable dose, reasonable duration, but only partial response was there. She wanted a rapid improvement to return back to the work. She was offered ECTs, but she refused ECT despite recommendations. Not willing to wait for another 8 or 12 weeks for a new drug trial or augmentation. So needed a fast acting alternative. So what's been tried so far? As a part of 2.0, SSRI, which had partial response. Now augmentation may work, but again time was a problem because you'll have to give some adequate time for augmentation. Another SSRI or SNRI may work, but again time is the concern. So what's 3.0 solution for this case? The speed is given by NMDA antagonist ketamine. Now let's know about this NMDA. There is a GABA interneuron between two pyramidal tract neurons, and on these GABA interneuron there are ionotropic glutamate receptors which are of three types: AMPA, NMDA and kainate. AMPA is a kind of engine starter. NMDA is actually the function of an engine which can be called as plasticity switch. NMDA is the gate opener, and some fine tuning is being done by the kainate receptors. Now we are aiming at NMDA here. Now what happens to NMDA in depression? Now this is again the same diagram: pyramidal tract, pyramidal glutamate neuron, two pyramidal glutamate neurons with one GABA interneuron in between. Due to the NMDA hyperactivity, there is more of GABA and less of glutamate. The distal pyramidal glutamate neuron has been inhibited because of the GABA overactivity. So there is more of GABA and less of glutamate, which reduces BDNF and which leads to synaptic atrophy. So this is what is the state of NMDA in depression. The moment we use NMDA antagonism, what happens is the GABA and glutamate balance is restored, which now you can see the distal pyramidal glutamate neuron has become more active. GABA has reduced, glutamate has increased, and now there is some balance in these two, and that increases BDNF and that promotes synaptogenesis. So this is how it works fast. So what does NMDA antagonism do? There's decreased NMDA activity on GABA interneuron, which reduces GABA release. So which disinhibits the distal pyramidal neuron, that is glutamate surge. The moment glutamate surge is there, the AMPA starts with that engine starter and the NMDA receptor gets stimulated. So AMPA receptor gets stimulated. AMPA activation increases BDNF release and mTOR signaling. So BDNF plus mTOR together lead to synaptogenesis, plasticity and circuit repair. So clinical outcome is rapid relief of depressive symptoms. Now Worth mentioning here is people use ketamine in two possible ways. One is IV and one is oral. The same drug can be used in an oral way. Now the IV has got more risk, but the IV will give you more of an AMPA action. So it will be having better relief of depressive symptoms if it's been used IV. Of course, it's high risk, high reward. The side effects would also increase. Oral will have lesser action of AMPA. Though it will have the NMDA action. So IV is better if you can handle the side effects. The NMDA path is taken by which drugs? Ketamine, S-ketamine. The blue ones aren't available in India as of now. So S-ketamine and D-cycloserine aren't available. The black ones are already there in India. Ketamine, memantine, DXM, which is also there in market now in combination with bupropion. So these drugs take the NMDA path. Apimostinel and it's still in pipeline. It's being tested. Magnesium has got NMDA action, but it's inhibitory action. Let's move to case 2. Mr. Rafiq, who's 23 years old male, a student, complained fear and suspiciousness, had social withdrawal, poor self-care, insomnia, hearing unreal voices, a clear case of acute psychotic episode. So what are the options we have? So option 1.0 is of course first generation antipsychotics, and most or many clinicians still feel, despite the protocols, despite the availability of SGAs, there are quite a few people who still feel comfortable with first generation antipsychotics. So he was started on haloperidol plus of course anticholinergics. The fear, suspiciousness and hallucinations reduced, but tremors and rigidity crept in. So SGA 2.0 option was started, which is second generation antipsychotic. Olanzapine was started. From haloperidol, olanzapine was started and he continued maintaining improvement. Now tremors and rigidity reduced because there is less of extrapyramidal side effects with these 2.0 options. But he started having weight gain and dullness. So now how do we go in this case? Because now we have got many options. So I would call this as 3.0 toolkit. From the receptor subtypes, the dimmers come into the play. Now, this is how the concept of partial agonism is. Partial agonism is in between full agonism and full antagonism. This diagram shows full agonism as full signal like a mobile towers. Antagonism as no signal, and partial agonism is variable signal in between these two. So partial agonism is more agonist than an antagonist and lesser agonist than a full agonist. So using D2 receptor partial agonism, now the patient is being treated on olanzapine. This is the spectrum of D2 partiality. At the upper end, that's completely D2 agonist, which is dopamine. At lower end, it's strong D2 antagonist or inverse agonist, you can say, is haloperidol. And in between are the drugs which have partial action on dopamine. So from haloperidol, it's risperidone, olanzapine, cariprazine, then brexpiprazole, aripiprazole, ropinirole. Ropinirole, bromocriptine, and dopamine are more dopaminergic. Aripiprazole downwards are kind of antipsychotics. So what you can do on this spectrum is you can move up the spectrum towards the agonist side, and then probably you can have the solution. So move to cariprazine or brexpiprazole or aripiprazole. Now brexpiprazole is also available. It wasn't available when I prepared for this lecture, but now it's available in India. And then you can have this spectrum. So this is one option. The option 2 is D3 receptor partial agonism. So the D3 drug is cariprazine. D3 density is more in emotion regulating areas, and partial agonism modulates dopamine and restores balance. So shifting onto cariprazine has got two logics. One is you move upwards from olanzapine in that partial zone, and also it's got predominantly D3 action, which might just help in this case. So this becomes another option. What else? There are few more options in this case. So in the toolkit, before we understand the toolkit, I think we should understand the psychosis network. There is an interaction between serotonin, glutamate, GABA, and dopamine, and this can be the schematic diagram of that. So usually it goes like this. The pyramidal glutamate neurons with GABA interneurons are connected to each other. They are located in PFC, prefrontal cortex. From RAFE, 5-HT output goes to this pyramidal glutamate neuron, which is excitatory, which is balanced by inhibitory GABA output. And the resultant glutamate output, one offshoot goes to visual cortex, the second offshoot goes to ventral tegmental area, and from ventral tegmental area, dopamine output goes to striatum. So this is how the interaction between 5-HT, GABA, glutamate, and dopamine takes place. So this means for targeting psychosis, we can try modulating glutamate, GABA, or serotonin because these are all connected systems. So what is there in NMDA and schizophrenia? In schizophrenia, there is hypoactivation of NMDA receptors. So we can aim via glutamate. So drug which has been, what I have done is I have included the drug examples which have been most extensively studied on these pathways. So luvadaxistat is a DAAO inhibitor. It increases D-serine and promotes NMDA receptor activation. Now, since NMDA receptors are hypofunctioning in schizophrenia, this NMDA receptor activation might just help. This drug, as of late 2024, has successfully completed phase 2 and now should be in phase 3 trial. I did not get any updates on this further. The second, we talked about GABA. So this is how the GABAergic system works. This is the GABA receptor, which is having 2 alpha isomers, 2 beta isomers, 1 gamma, alt, delta, theta, epsilon, or pi isoform. And there's a chloride ion channel in between through which the chloride ions pass. So this is how the structure is. The drug which has been tried most is darigabat. Unfortunately, this did not do well in the trials of schizophrenia, but this has been targeting GABA A alpha 2, 3, or 5 receptor subtypes. So it did help targeting cognitive deficits and has been or being studied in anxiety depressive disorders. So unfortunately, though theoretically GABA has something to do with the connections, the GABAergic drug or GABA target in schizophrenia did not work, but it did show some promising results in anxiety depression. Serotonin. Now, serotonin also figured out in that connection system. So 5-HT2A, 5-HT1A, and 5-HT7 seem to be the receptors which find some use in targeting psychosis treatments. 5-HT2A antagonism or inverse agonism has got significant role. Now we have drugs which are targeting these. 5-HT1A partial agonism, kind of downstream effects come to the same as 5-HT2A antagonism, and so it has got role in treating negative symptoms. 5-HT7 has antagonism has got role in cognition deficits. So these serotonergic drugs using these pathways have shown promising results in treatment of schizophrenia. Now let's see how 5-HT2A and dopamine are linked. From prefrontal cortex, there is glutamate output to substantia nigra or ventral tegmental area. From there, second neuron starts, which is dopaminergic neuron, which goes to emotional stratum. Now, glutamate is excitatory neurotransmission. It increases dopamine to emotional stratum, and this leads to positive symptoms. The moment we block 5-HT2A, 5-HT2A antagonism reduces glutamate drive. This reduces dopaminergic drive and cooling off the circuit to emotional stratum, reducing positive symptoms. This is mechanism number 1. This is mechanism number 2. From prefrontal cortex, again there is a glutamate output to substantia nigra now. There is a GABA interneuron and then dopaminergic neuron starts to motor stratum. Glutamate increases GABAergic activity, which cools off the dopamine to motor stratum. So dopamine reduces, which reaches motor stratum. Since dopamine to motor stratum reduces, there is EPS because muscle, the movement smoothness reduces. The moment we block 5-HT2A, the glutamate output reduces, GABA is inhibited, and there is lift of brake on dopamine neurons. And as a result of that, motor striatum gets activated and the EPS reduces. And there's third and last mechanism, which is from prefrontal cortex, glutamate goes to ventral tegmental area. Again, there is a GABAergic interneuron involved. And then that GABAergic neuron or GABA output reduces dopamine output back to prefrontal cortex. This leads to emotional blunting and flat affect. The moment we block 5-HT2A, the glutamate reduces, GABA is inhibited, the dopamine to since GABAergic inhibition of dopamine reduces, it's like minus minus plus. So dopamine to prefrontal cortex increases, and that takes care of emotional blunting and flat affect. These two reduce. So this is how 5-HT2A antagonism helps in three ways. So which drugs use that? 5-HT2A antagonism is used by almost many of the second generation antipsychotics. Predominant are clozapine, olanzapine, risperidone, ziprasidone, and paliperidone. 1A agonism or partial agonism is being done by cariprazine, brexpiprazole, and aripiprazole. And 5-HT7, the main 5-HT7 drug is lurasidone, of course, being also used by paliperidone and cariprazine. There's one more option to treat psychosis, which is acetylcholine and dopamine. There is a role of M1 and M4 receptors. So what is seen is anticholinergics counter the inhibitory effect of acetylcholine on dopamine. So anticholinergics indirectly cause a relative rise in dopamine. We also have seen the organophosphorus patients being treated by high dose anticholinergics develop psychosis. They call it as atropine psychosis. The reason being anticholinergics indirectly cause relative rise in dopamine. So now there is a drug combination which is coming up, which should be there shortly in India, which is xanomeline tropsium. It's a fixed dose combination. M1 and M4 muscarinic receptor agonist is xanomeline, and tropsium is peripheral anticholinergic. This has been approved by US FDA in September 2024 as a fixed dose combination in schizophrenia treatment. So it's already an approved drug. What happens is xanomeline is M1 agonist, which improves cognitive function and reduces negative symptoms. M4 has to do with dopamine. So M4 agonism reduces dopamine indirectly. Now this will lead to more of cholinergic drive, and it will have peripheral cholinergic side effects. So tropsium blocks peripheral cholinergic effects. So it's a peripheral anticholinergic. So this combination works, and that has been used and approved by US FDA. There's one more option, which is TAAR1 receptors, trace amine associated receptor type 1. The location of this receptor is prefrontal cortex, nucleus accumbens, ventral tegmental area, hippocampus, and substantia nigra. So emotion regulating area predominantly. Activation effects are it inhibits dopamine neuronal firing, which leads to reduction in psychosis, reduces dopamine synthesis, reduces dopamine reuptake, and modulates 5-HT and AD. So multifold action. So TAAR1 activation results in antipsychotic effects. The result is excess dopamine signaling is reduced. No anti-dopaminergic side effects also, because there is some modulation of dopamine, and there is some possible benefit on mood and cognition as well. The phase 3 trial in schizophrenia has been done with uloterone. This is being tried as of now. So the total 3.0 toolkit for treatment of psychosis, let's refer back to the basic case of acute psychotic episode, is D2 partial agonist, selective GABA A alpha 235 modulator, not very useful though, NMDA agonist or partial agonist, muscarinic M1 M4 agonists, muscarinic M1 M4 agonist. So that's been an approved option. 5-HT2A antagonist or 1A partial agonist or 7 antagonist. So these are options, and TAAR1 agonist. So this makes the total toolkit of 3.0 in treating psychosis. Let's move on to third case, which is of Mr. Ravi, 76-year-old male, retired government servant, has got Parkinsonism on levodopa and carbidopa and pramipexole, developed visual hallucinations and delusions of persecution. Now, what happens is if we use 1.0 option of antipsychotics, the strongly reduced the 1.0 options of treatment is slowly reduce pramipexole, reduce levodopa and carbidopa. So Parkinsonism worsened because you stop the dopaminergic drugs. So this was a 1.0 option. Of course, 1.0 antipsychotics we cannot use because Parkinsonism will worsen. So this did not work. 2.0, restore back anti-Parkinsonian doses, add quetiapine. The response was there, but it's inadequate response. So 2.0 options we have so far. Let us discuss those. First is clozapine. Now two red arrows indicate D2 and 5-HT2A. So it's about the 5-HT2A to D2 ratio, which will define the drug-induced Parkinsonism causing ability of a drug. More the 5-HT2A, lesser the D2, lesser will be the Parkinsonism. So from the left side, if you see of the screen, the 5-HT2A option is first and D2 option is later. So this drug, of course, has got lesser EPS. The second option we have is quetiapine. Again, similarly, it hits 5-HT2A first and then D2, so lesser EPS. Now let's compare these two options. The green arrow, bigger the green arrow, lesser will be the EPS. Now in these two options, we have the arrow is slightly bigger with clozapine than quetiapine. So clozapine has got better kind of action when it is thought about only antipsychotic action without worsening extrapyramidal. But clozapine comes with its own side effects. And what's more important is the flashing violet squares. Now, what do these squares indicate? These squares indicate even before 5-HT2A action is triggered in by both these drugs hit some targets which cause dizziness, dry mouth, drowsiness, cognitive dysfunction, weight gain, constipation, hypotension, and blurred vision. So these all start happening even before even 5-HT2A is triggered in. So these drugs come with their own problems. So now we want some precision. Again, let's go back to the psychosis network. Now, what happens to this psychosis network in Parkinson's disease psychosis? We know that in dementia, there are beta amyloid plaques and neurofibrillary triangles and Lewy bodies. But interestingly, the neuropathology of dementia and Parkinson's, they share about 50% of the neurobiological problems. As a result of that, the beta amyloid plaques and neurofibrillary triangles and Lewy bodies, they are also there in Parkinson's disease psychosis. And what they do is they reduce the GABAergic inhibition onto 5-HT action on pyramidal glutamate neuron. As a result of that, there is disinhibited glutamate action, and as you see, the more glutamate flows to visual cortex, you will have patients having direct visual hallucinations. This is the basis of visual hallucinations in Parkinson's disease psychosis. Now, the moment we block 5-HT2A we insert 5-HT2A antagonist, the GABA effect is negated. As a result of that, the glutamate and dopamine reduce back to normal. And this is how 5-HT2A antagonism, precise 5-HT2A antagonism, helps in PDP, Parkinson's disease psychosis or dementia-related psychosis. So a 3.0 toolkit in this regard is pimavanserin, which is a 5-HT2A inverse agonist or a strong antagonist. It also has got 5-HT2C action, but which we can neglect because it is negligibly less. Let's move to case number 4. Seema, 30 years old female housewife, has got postpartum depression, not taking proper care of the baby. Depression is of moderate severity and unwilling for ECTs. SSRIs are as slow as a tortoise in such cases because we want this lady to become all right as soon as possible because she has to take care of the baby. So now the 3.0 action, 3.0 option is brexanolone, which is a positive allosteric modulator at GABA receptors, and this delta subtype is crucial for this drug. This is being administered right now. It's not available in India, but this is metabolite of progesterone and allopregnolone. It works like allopregnolone. And then this has to be given as a 60 hours infusion. Starts with some 30 microgram per hour, then it goes to 60 micrograms, then 90, then back to 60 and back to 30. And there is a schedule how to give it. So this is something which is supposed to work in 60 hours or something like that. Let's move to fifth case. Arjun, 32 years old male IT professional, known patient of bipolar affective disorder and is currently depressed. On lithium and SSRIs, which is a 1.0 option or a combination of 1.0 and 2.0, he had tremors, not happy with frequent monitoring of lithium. So another option is approved second generation antipsychotics, which are lurasidone and quetiapine. Quetiapine causes sedation and lurasidone caused akathisia because lurasidone has got significant antipsychotic action. So what else? So 3.0 option in this case becomes lumateperone. Now what's different with lumateperone? Lumateperone has got significant 5-HT2 antagonism. 5-HT2 antagonism is about 60 times that of B2 blocking. So it reduces EPS, there's virtually very less EPS. Reduction in negative symptoms, works as anxiolytic, pro-cognitive, but there is some possible sedation. So this is how it happens. If you see here, what is different with lumateperone is this D2 presynaptic partial agonism. In addition to postsynaptic D2 antagonism, it's got presynaptic partial agonism. As a result of that, presynaptic partial agonism reduces dopamine release because the presynaptic sensor remains intact. So though the postsynaptic due to antagonism is very less or having less strong action, presynaptic action reduces dopamine neurotransmission. So net result is good antipsychotic activity despite weak D2 antagonism. So lumateperone also has got some D1 and glutamate action, which increases synaptic plasticity, synaptogenesis, and NMDA receptor mediated glutamate increase. There are some more 3.0 solutions to some important concern areas which are beyond these cases. First is SSRI induced sexual dysfunction. Now here 5-HT1A partial agonism helps, which has been used by vilazodone and vertioxetine. Vertioxetine has got 5-HT3 antagonism which increases dopamine, 5-HT1B partial agonism which increases dopamine, and less SCRT inhibition. As a result of that, these drugs, despite using serotonergic pathway, have got lesser SSRI induced sexual dysfunction. Another concern is metabolic side effects of antipsychotics. The drugs which have got minimal actions on H1 and 5-HT2C, which are lurasidone, cariprazine, and lumateperone. So this is a range of antipsychotics which is reasonably free from metabolic side effects of other antipsychotics. Let's move to case number 6. Mrs. Neela, 45 years old female lawyer, had got primary insomnia for 8 months, taking long to fall asleep, frequent awakenings, daytime fatigue and irritability. Also had poor concentration. So 1.0 option, benzodiazepine, there was next day dullness, memory lapses, fear of dependence. 2.0 zolpidem or melatonin. Zolpidem, she felt like it's a forced kind of sleep, and parasomnias were also there. Melatonin had very mild effects, so she was not happy with melatonin. So 3.0 solution here is physiological sleep restorer, which is targeting DORA, dual orexin receptor antagonist. So OX1R and OX2R are in hypothalamus, they modulate wake switch. So this DORAs cause the sleep the sleep effect of DORAs is very close to the natural sleep. So suvorexant and lemborexant are lemborexant is available in India. Suvorexant soon likely to come in. So these are drugs which, though as of now are costly, they are very physiological sleep restorers. Case 7, Master Arnav, 10 years old male student, has drug resistant epilepsy due to Lennox Gastaut syndrome. He is on multiple anticonvulsants, valproate, clobazam, levetiracetam, still continues to have frequent drop attacks and tonic seizures, which impairs his schooling and day-to-day life. So what's the 3.0 solution? It's cannabidiol, which is a CB2 receptor modulator. These are exogenous cannabinoids. The psychoactive is THC, delta THC, and CBD is the other range, which is non-psychoactive, anxiolytic, and convulsants. So it has got been implicated to neuropathic pain, anti-inflammation, and this action can be patient-specific. But this drug can be used as an adjunct to epilepsy case. Case number 8, Ramesh, who is 42 years old male driver, has got daytime irresistible sleep, snoring during sleep. He feels tired and has past history of one seizure 8 years ago. So 2.0 options are modafinil or armodafinil. The symptoms do improve, but anxiety increased, headache started, and he had one episode of staring blank look with history of one epileptic seizure 8 years back. No one would be very comfortable using modafinil or armodafinil, though the risk of seizure induction is not as high as amphetamines, but still there is some risk. So the stable or better option becomes pitolisant, which is again available now, which is a H3 inverse agonist, presynaptic H3, which are autoreceptors. It works as inverse agonist at that level, increases histamine levels, which is a natural wake mechanism and has got more physiological alertness. So this works as a good option as a 3.0. Case 9, Mr. Samir, 42 years old male, meticulous bank manager, has got chronic anxiety, body aches, poor sleep for months. Alprazolam symptoms reduced but had daytime dullness, and of course there was fear of dependence. SSRI's mood improved but inner tension persisted, so it wasn't very great result. So what he needed was 3.0 option tranquility, which is a sigma receptor acting drug opipramole, which works on sigma 1 and sigma 2, works as sigma 1 and sigma 2 agonist. The other sigma agonists, of course, are fluoxamine and sertraline. Now let's talk about some more receptor targets. Opioid receptor targets. There are 3 types of opioid receptors: MOR, COR, and DOR. Now mu type, the activation causes analgesia and euphoria, can cause respiratory depression. Morphine is a very restricted substance used in only a few cancer cases. Buprenorphine is a partial agonist, can cause pain relief, less euphoria, less respiratory depression. It has got some role in opioid dependence treatment. KOR, activated by endogenous peptide, which is dynorphin. Dynorphin is active during stress. So activation causes dysphoria, stress, and anxiety, which means blocking KOR might reduce negative side effects. The drug which is supposed to do that is aticaprant. And the third, which is under study, is DOR. Activation causes mood improvement, anti-inflammatory effect, and neuroprotection. These drugs are under study, which is KNT 127 and SNC 80. These are under trials. The drugs would get some generic names after the trials are completed. So this is where we are as of now. What are the future receptor targets? Glycine modulatory site of NMDA is being targeted, which has been known to be a target for cognitive and negative symptoms. Sarcosin and D-cycloserine are the drugs which are being tried for this. AMPA receptor potentiation, we talked about NMDA, AMPA and kainate, out of which AMPA, as I said, is an engine starter. So AMPA receptor potentiation could actually even improve depressive symptoms faster than ketamine. So this is also a target for cognitive and depressive symptoms. Some drugs CX516 and CX717 are being tried for this. Alpha 7 nicotinic receptor is being targeted for cognitive and negative symptoms. And EVP 6124 and ensinicline is being tried for this. V1B receptor, the vasopressin receptor, has been attributed to stress and HPA axis modulation in depression and anxiety. ABT 436 and TS121 are being targeted for this. Glucocorticoid receptor modulation for stress adaptation is being tried. CORT 128297 is the drug under study for the same. So, to sum up the new age receptor story, psychiatry is surely moving from intrapsychic conflicts to intracellular signaling pathways. And that's it. Thank you so much. Thank you so much for listening to me and giving me an opportunity to talk to you. I thank the entire psychopharmacology specialty section and IPS president, secretary, treasurer, and the entire IPS executive council for giving me this opportunity. Thank you so much.
So wonderful presentation and quite informative, I must say, and covering the newer drugs and whether where they can be used. So it is a wonderful kind of presentation. There are some questions in chat box,
Yes, sir.
and anybody wants to interact, they can raise their hands or write in the chat box. So first question is by perhaps Ipsita Basu. So, sir, how do AP mostinil and MG act, magnesium act on NMDA?
Magnesium has got a different action. Actually, magnesium will be a inhibitory kind of drug. So it will reduce neuronal excitability. So which will have some effect as an adjuvant drug when we use it. But it on its own will not have a very strong action like the prime psychotropics. So maybe it can be used as an adjuvant. But it's an interesting drug because if we I removed that slide actually how that NMDA receptor works. The magnesium block uh, has to be removed before that calcium ion influx starts in the cell. So if there is more of magnesium, the magnesium block is not reduced, and as a result of that, probably the activation does not happen.
So thank you. Second is Dr. Pramod Thakre is asking what role are neuromodulators versus neurotransmitters? Modulators versus neurotransmitters. Classic.
So, sir, modulators will be now the in thing because as I said that now we are traveling to the dimmers. So modulation of a receptor will be like stabilizing action on that receptor. Rather than full way going for agonists and antagonists, now we are talking about the action which is in between these two actions, and the excess is not needed and minimal is also not tolerated. So modulation does help. So modulation is the new thing which will help now.
One case, ketamine versus RTMS.
Ketamine
So
versus
probably in suicidality or
in
resistant
suicidality,
depression.
again, if I have to talk about my own opinion, in suicidality, I would still rate ECT better than both of these. That's number one. And if not ECT, is the second most established option is lithium carbonate before even these two, because the ketamine action is there initially, but the studies show that it does not last for a long time. And RTMS, I mean, it's little too weak for somebody who's suicidal. So I would suggest that ECT as choice number one. If not, choice number two is of course lithium carbonate. So
Great. And
neither ketamine nor
ketamine,
again,
of course, that it works very fast, but again,
it doesn't
the
last long,
action does not persist. So
persist.
that is the issue. And
For a
maybe with
short duration, it can be used.
so হ্যালো, একটু পরে করছি, আমি একটা মিটিং আছে, দাঁড়া, একটা অন্য মিটিং আছে, হ্যাঁ ঠিক আছে, করছি। হুম, হুম। So another question is that uh, pitolisant can be used for drug-related drowsiness.
Absolutely can be used for drug-related drowsiness. We may not have a classical narcolepsy kind of scene to use pitolisant. Drug-induced drowsiness will also respond to pitolisant to some extent, though the basic prime action will be reduction of sedative drugs or shifting to lesser sedative options from the same segment. But beyond doing that, if at all drowsiness persists, you can use pitolisant, but dose of 4.45
হ্যাঁ, হ্যালো
mg.
হ্যালো, হ্যাঁ ওকে, হ্যাঁ 5 মিনিট পরে করো, আমি অ্যাকচুয়ালি এটা সিস্টেম শেয়ার করছি, হ্যাঁ।
The
And
dose
again, role of indoxafen, sorry.
the dose of 4.45 mg will not be useful. You will have to do for something like 17.8 or higher dose.
So very interesting question, role of GLP-1 agonist.
Okay, GLP-1 agonist is, it will be a part of metabolic syndrome. I mean, it's a metabolic drug. So maybe it is not a core psychotropic per se. Per se, it's not a core psychotropic. But yes, it is coming up, and there is some evidence of use of GLP-1 in psychiatry, but it's still quite a new thing. And GLP-1 cannot be a psychotropic target. So I eliminated that from this, but it will be having some role in psychiatry.
Subcutaneous ketamine and its abuse potential.
I think that effect wise, if you really consider, the best is IV ketamine. If you can handle the side effects of that, because IV will be high risk, high reward. If not, then maybe oral ketamine. I know quite a few people who have been using oral ketamine to some effect, and they are happy with that. But if you want that actually really that AMP and the speed, it's got to be IV, because oral and the other modes will activate the NMDA. You will miss that AMP action.
So Dr. Shwara is asking of experience of NMDA agonist in clinical practice.
So NMDA agonist or antagonist?
Hmm.
Antagonist. Antagonist. So as we just discussed about ketamine, yeah. So I think it's she's asking about ketamine, is it?
NMDA.
Sir, hello.
Yeah.
Sir, I'm asking about NMDA agonist as you discussed its role in
D-serine.
schizophrenia.
Yeah. D-serine, you said.
Yeah, D-serine. So
Yeah.
is it
These
used?
these are being tried. These are being tried.
Okay, so it
As
is
of
not
now,
yet used in
yeah.
as
No.
treatment. Okay.
I said it in, I mentioned it in future directions.
Future directions. Okay.
Yeah. See, as you see, there are two attachment sites to NMDA receptors, one of which is used by D-serine. So NMDA activation, D-serine has got a role, but it's under evaluation.
Okay, thank you, sir.
Yeah.
Govind sir, Dhananjay here.
Yeah.
Sir,
Dhananjay.
which drug you mark as a revolutionary in this decade, last decade, considering the targeting the receptors
Out of these,
out of all this?
difficult to comment. But those which I mentioned, I had been a part of the brexpiprazole trial and lumateperone trial, which were phase 3 trials pre-launch. I found
Yes.
both of these drugs to be very good actually.
Mhm.
Particularly brexpiprazole, it's got a significant different action than aripiprazole. Though on record, both drugs look pretty similar. They start with different receptors. So brexpiprazole is distinctly different in some ways than aripiprazole, though they share the same segment of dopamine partial agonism and 5-HT1A, 5-HT2A partial agonism. It's quite
But
different from each
uh,
other. So
personally, I have seen less kind of akathisia with
less akathisia, less
um,
activation
less
with brexpiprazole.
brexpiprazole is again side effects is less than the aripiprazole.
Yes. So
So
at least initial
and
doses,
efficacy I don't know still.
efficacy is
Maybe
almost
him
at par, almost at par.
part.
But if it's about you need an activating drug, something like if you are using it in augmentation of depression, then aripiprazole might just be a touch better drug. If you are handling with a condition where which is kind of psychotic anxiety, then brexpiprazole will be a better drug. So brexpiprazole seems to be a good drug as of now. It's little too early to comment. So seems to be lumateperone. Amongst the all options we have in treating bipolar depression, which we can say OFC, olanzapine fluoxetine combination, quetiapine, lurasidone, lumateperone, then maybe something like lamotrigine. I feel that if we study NNT and NNH, probably lumateperone scores over most of these options. So lumateperone will also need a fair trial before we conclude on that drug. So these two I found interesting. I found pitolisant also pretty interesting. I've been using that also.
Okay, I have not been using today. After that, I will.
Yes, sir.
The maximum dose of break, sir, in adult
4 mg.
schizophrenia.
4
4
mg.
mg. Okay.
And again, role of naltrexone in impulsivity.
Role of naltrexone in impulsivity. Again, naltrexone, I think is more about, if I have to list the molecules for impulsivity, my first choice would go to the time-tested 1.0 option, lithium carbonate, if it's impulsivity. Option 2, if I have to use a new option, maybe endoxifen better than naltrexone. Naltrexone would reduce the dopaminergic surge. So dopaminergic surge reduction may not do that great for impulsivity. So we reach the dead ends quite often, and we need drugs which kind of have labels of can be tried. But then established options and confirmed useful options are lithium carbonate and oxyfen.
Endoxifen is much better. And
Yes,
naltrexone basically reduces all the activities
yes.
rather than, as you have already mentioned.
So it's dopamine
Uh,
surge with it.
it is not that impulse per se. So it has
Yes.
again a lot of other kind of baggages with it. So a lot of praise and a lot of comments that new molecules has been dealt very fairly and very good. I must
Thank you,
say
sir.
that.
Thank you, sir.
So any more questions from anybody? Okay, over to Ramandeep and
Sir, just last one, sir.
yeah,
Govind sir, there are many
Dhananjay.
fancy doses are coming. 34, 42, 105. We even nowadays? What is logic behind that?
I don't know. These drugs are being tried in those doses. Maybe I really don't know what is the pharmacological thing behind that. But this is interesting. I mean, of course, a non-scientific comment. Don't you think that these doses for educated people might just add to the placebo component?
Possibly, sir, possibly.
No, but internationally also the doses are these odd doses
Same.
only.
Mhm.
So these drugs probably the formulations come up in those doses. So that could be the reason.
Okay.
They may not
Okay.
be available in rounded up doses. I don't know that.
Thank you, sir. Thank you.
It's a
Thank you, sir.
pharmacology tech.
Yes. Sure.
Okay, so it's 9:30.
Again, another question, opipramol versus buspirone.
Opipramol versus bispirone both handle different receptor systems. So both will have effects on different kinds of anxieties. So if you are aiming at anxiety being targeted the serotonergic way, you go for different drug. And if you are trying to target it the sigma way, you go for opipramol. I happened to meet Dr. Hans Moller once. Hans Moller is the German psychiatrist who has been a part of opipramol's the first ever drug trial in the world, the German trial. He said that they use opipramol as in Germany as a kind of general purpose anxiolytic. So it's general purpose anxiolytic. So maybe if you're not narrowing down to any specific kind of anxiety and it's amorphous kind of anxiety, maybe then you use this opipramol. So that was his take. I remember that word general purpose anxiety. So I have remembered that because since it was from the original researcher, we could buy it straight away, though it was a corridor knowledge. Uh, Coming to other drugs, they have got specific actions on anxiety, and if we feel that the neurobiological basis is that kind of targeting to that receptor system, then yes, we can go for these specific drugs. Bispirone will of course be the serotonin way.
So almost covers Jepirone. Any comment on that?
Which
Jepirone, I don't know. In which patient profile would Jepirone be the choice of drug? Whether it is in market, I don't know.
I'll read the comment.
Last but one, Dr. Ipsita.
I think I don't know this.
I also have heard about molecule, but not know the details. Anyway, thank you, sir. And as someone said, hope we are doing quite well psychopharmacologically if we choose drugs judiciously. So it is not only question of hope. There is no place of nihilism, because what I say that our patients have now best prognosis in a lot of things. So other people are treating our patients because has so much better prognosis, better treatment options. So with this, thank you, and over to Dr. Ramandeep.
So thank you for a very interactive and informative session. We had the audience with us, which was stable throughout the session for 1.5 hours. And as Lisa said, yes, hope is the path forward. And it's good to see in the last few years several new molecules coming after a long period. and also many more in pipeline. So we hope that as we go forward, our patients will have many more options than they presently do. Also encourages the research in psychiatry. Because there was a time the pharmaceutical industry also had stopped investing. And now with at least some molecules doing better. And even for the conventional disorders such as depression, for example, for postpartum depression, steroids now are the main drugs of choice. So we hope more and more those be open, and both clinicians and patients will have many more choices than that. So, first of all, I thank the audience for participating actively and for putting in a lot of questions, and also a lot of engagement in chat box and a lot of positive remarks about the session. We thank Dr. Govind Kulkarni for taking up this topic. It's a cutting-edge topic, and also trying to simplify and present in not only the theoretical part, but also aligned with the practice, taking up the cases, the case summaries which we presented. So thank you for an informative talk. And I thank Dr. Gopi sir for chairing this entire session, but also for his remarks, sharing some of the practical experiences. Now this session, of course, was planned by the IPS Psychopharmacology Specialty Section, and the chairperson of the show could not be here today. And we had commented on Dr. Arun Markwati sir. Simon, I could see in the audience also. So this was the combined effort of the entire section. And we also thank the Indian Psychiatric Society, under whose aegis this webinar is being held regularly. We hope to see the audience participate periodically and regularly. And the specialty section would also try to give in more engaging and newer topics, which are of interest. So with this, we wind up. Good evening.
Thank you.
Thank you, everyone. Good night.
Good night and bye.
Good night, sir. Thank you.
Good night.
भेटू सर पुढच्या आठवड्यात.
Yes, Betu.
Yes.
Bye. Thank you.